My talk is going to be, I don't know, similar, I think, a little bit different, maybe in style. And I decided to pick 4 different things to address. And they're just sort of out of the, I didn't pick MGD. You got an earful on that earlier. But I have one on lid hygiene, what matters. I have another one, contact lens intolerance is not dry eye, punctal occlusion and underappreciated art, and scleral lenses and adaptation. So these are the 4 things I'm going to hit on actually pretty quickly, I think. So, lid hygiene, what matters? The old standard was Johnson's baby shampoo. How many people here have been told or have used Johnson's baby shampoo? Okay, I'm looking around, a fair number. There is 0 evidence on Johnson's baby shampoo. And Johnson's baby shampoo of today is different than the one of 50 years ago when it was first recommended. I mean, there were and are still patients with really crusty, nasty-looking lids, okay? That was like in-your-face blepharitis. You don't need a slit lamp. We're not counting Demodex mites, deciding if they're sleeves or collarettes. It's like really crusty, yucky lids. And they were either symptomatic or they were about to have cataract surgery, and the lids needed to be cleaned up. And the doctors had to come up with some regimen. And somebody, I don't know who, I tried to research this, figured out that you could, they figured they needed soap to get through the greasy crust. And they figured baby shampoo was probably the gentlest of any liquid soap. There weren't even liquid soaps then. I mean, hard to imagine, but pump soaps, that's a new thing. Soap was a bar, right? And you washed your body with a bar of soap. And even shampoo is a relatively modern concept. Now, none of us are, I'm not old enough. It existed when I was a child, but things like Prel and Breck were pretty new. They were post-war. Before World War II, I don't know what people washed their hair with. Probably, I don't know, bar soap, right? Think about it. So Johnson's comes out with a gentle shampoo called No More Tears. And I apparently was a nasty baby in the tub, and I was very compliant for most things, but I made a terrible fuss when she tried to wash my hair. And she had that. I grew up with that. It stings like heck. I ask any doctor who prescribes it, have you tried it on your own eyes, first of all? And you're supposed to dilute it and use a moist cotton balm and do all that. But how many people back then who recommended it did it? And then Johnson's baby shampoo now is not what it was. It has all kinds of conditioners and emollients and additives and other stuff. So it might have been almost like a plain soap back then. It also no longer says No More Tears. That was an advertising thing implying that it'd be gentle and keep your baby happier. But the answer is that there's never was any evidence on baby shampoo, even though it was widely adopted. And then baby shampoo changed. And the regimens for hygiene have not been scientifically validated, none of them. Even though many of you and us have these elaborate rituals about what they think matters. I'll do it this way. So this is what I think. Nothing matters. It's like from that Queen song, nothing really matters at all. Nothing matters. It's all about what makes you feel better. So I'm getting back to symptoms. I believe warm compress is probably good. Hot is not better. Now, I'm an MGD non-believer as a disease, but I do believe whatever's in our glands can be waxy or oily, and we want to keep it in the oily state where it'll do a better job reducing evaporation. So I think warm compress is probably a good idea, especially if it makes you feel better. Hot is not better. There are some people, I'm very careful not to call it hot compress, because some people think if warm is good, hot must be better, right? You're trying to melt butter, so you put the microwave on 10. No, bad idea. It blows up in the microwave. Melt your butter on 3, okay? Scrubs can be irritating of any kind. So I used to recommend, when I stopped recommending baby shampoo, I started to recommend lid scrubs. Different companies make them. Some of them are represented here. And I looked, and they had the same ingredients as non-oily eye makeup remover, so I also recommended that. And I said, you can buy Almay or Maybelline. You don't have to buy Lancome or the really fancy ones. But non-oily eye makeup remover or scrubs, if it makes you feel better, do it. Hypochlorous acid spray came out, I don't know exactly, about 10 years ago. Avenova was the first, so I listed them at top, but I have no brand loyalty. And I like these. I think they make a lot of sense. They're not proven to be better, but they have antimicrobial capability. I do think they can reduce Demodex load, and they're non-irritating. So that's my tidbit on lid hygiene, okay? What matters? The most thing that matters is, does it make you feel better? Now, this is a big one. Contact lens intolerance is not dry eye. A lot of people end up in the eye doc's chair because they were doing well for a while in contacts, and suddenly they can't wear them as much as they used to. Their eyes get red, their eyes bother them, they want to take them out at the end of the day. They go to the prescriber and explain that they can't tolerate them as much, and they're told that their eyes are dry. I don't know if they've had Schirmers. They might look dry. I don't know. It's really a separate issue, and you'd have to work them up for aqueous deficiency. But most are told simply that it's dry eye, and patients come in saying they have dry eye, but there are a lot of maneuvers that can and should be undertaken for lens intolerance before it's put in the wastebasket of dry eye. The same DEWS people, the people who supported TFOS, I'm sorry, they're called TFOS, they supported the DEWS workshop. They supported a big workshop on contact lens discomfort. As part of that, I sat on the therapeutics committee, and we did a deep dive into the literature. And the only treatment that makes a difference for contact lens tolerance of all the dry eye treatments is punctal occlusion, punctal plugs. We came up with this algorithm, and it's complicated, but it involves sad faces and then one smiley face, no problem with tolerating the lenses. And it talks about how you sort out what to do for someone with contact lens intolerance. And it involves making sure they're on the best possible solutions. Now we have daily disposables, making sure it's not the fit, things that you can maneuver to improve the tolerance. There's expectation. All of our eyes make less tears, make less lipids, make less mucin with age. So we have to accept that. We had no contact lens intolerance when we were in the era of rigid lenses because most people only wore them 10 hours a day. But people wear soft lenses 18 hours a day, and they want to do that from when they're 12 years old until when they're 40. And we're all a bit drier in all three layers of the tear lake by then. So I will not accept contact lens discomfort is its own entity, and the most effective treatment for increasing patients' wearing time, once you've removed the problems with the lenses themselves or optimized things, is punctal occlusion, which brings me to the next one. Punctal occlusion, an underappreciated art. So the language is complicated because we have tear glands that secrete into a duct, but that's a different duct than the one that drains the tears away from the eye. And we can improve the tear lake on the surface of the eye by blocking the drain. I'd say it's like a shower in a bathtub. And if you want the water level to be higher, you just have to, and the water's coming out at the same rate, if you change the flow in the drain or put a plug in, you'll have more water on the surface. So if you put a plug in the drain, you can improve the tear lake, and you can improve lens tolerance, and you can also improve symptoms of ocular surface disease. There are different ways to block the tear drain, and I've left some out. but generally speaking, there are dissolving plugs, silicone plugs, and cautery. There are dissolving plugs made of purified animal collagen. They look like tiny rice grains. There's confusion out there because a lot of clinicians, ODs and MDs, call all dissolving plugs collagen plugs, but it's just not so. Collagen is collagen. It's a purified animal product. Those only last a few days. The other dissolving ones are different polymers. They're related to dissolving stitches. They're advertised to last 90 or 180 days, but it's never been proven or tested. And there's now another polymer, lacrophil, that can be put in the system. But those are dissolving or removable, totally internal. There are silicone plugs that sit at the opening. Finally, there's cautery, where we scar the drain shut. And in the do stepwise, cautery was way up there at number 4, but I can tell you that I'll do that much sooner for some people if they think it's going to benefit them. Here's some more pictures on what these look like. These are the dissolving plugs. They're put in with little forceps in the chair. You can railroad track them. They're silicone plugs that sit at the end of a stylet, and you pop it in at the opening, and then the cautery. The art of how I offer this is I offer it as a therapeutic trial. I do the upper and lower both in the affected eye or eyes. That's because the dissolving ones only block partially, and they start dissolving right away. We want to get the most bang for the buck. I put the biggest size possible for maximal effect. I learned that most of my colleagues at a very famous institution where I work just put in the 0.3s, the smallest size, because it's easier and faster for them. That's interesting. But that's not the point. I want to put in the hardest ones to get in, because then it's the most bulk to dissolve for the sake of the patient. I schedule 2 follow-up visits, one at 2 or 3 weeks and one at 3 months, because I want to talk to the patient while they're still experiencing the effect of the plug and nothing else to find out if it's helping them, because they do start to dissolve. And by 3 months, the effect is going to be gone, and they may not remember, or they may have other things going on, or tried other drugs or this and that. Again, most of my colleagues don't want to see dry eye patients back that soon. They find all the dry eye patients very annoying, so why would they bring them back? But I think it's very important to bring them back. And now I say thank goodness for COVID, because that allowed us to start making telephone encounters. And so now I don't make people come in and pay for parking and sit in my waiting room for 2 hours for me to just say, how do the plugs work? I schedule telemed phone follow-ups, and we talk about their experience with the plugging. And then we already have the next visit lined up, and we go forward. In the 2 or 3 week phone call, I find out if they have relief, tears overflowing or not. I want to make sure they have no tears overflowing. Then we plan to do either silicone plugs or cautery at the next visit. When I go to permanent, I do the lowers only, because the partial never block completely. And I avoid cautery in those under age 40. I don't want to distort the lid margin, and it truly is permanent, and maybe hope springs eternal. I hope they have a reversible condition. For silicone, I put in the biggest I can without dilation. I want it to sit nicely. There's a problem with some lid structure that when they blink, the lid turns inward. That's the Asian lid. Or in some people, the punctum is more on the mucosal side. They're not going to tolerate silicone plugs. So if I put those in, I try not to do it on a Friday. And I have them sit in the waiting room, because it's much easier for me to take the plug out if they stayed in the waiting room than if they got on the Southeast Expressway to get out of Boston and they're stuck in traffic and they can't get back for an hour and a half and park. So this takes time. It's different than how most of us practice. I don't put the uppers in until we prove that the lowers have been beneficial, but insufficient, and then I bring them back and do the uppers. So that's a more elaborate approach. Most of my colleagues say, oh, you have dry eye, plugs can help you, I can offer you dissolving plugs, boom, boom, boom. They put in lowers only, or I don't know what they do. And then the patients come back and say, well, it didn't help that much. But the patient expectation wasn't set right, the mechanism wasn't described, and there wasn't proper assessment. I find that punctal occlusion is generally underutilized, and I can't say why, because I really find it very, very, very important in my practice. But I see many, many patients who have not been offered punctal occlusion. And I have a feeling most people don't do it this way. This is my last little tidbit. Am I okay for time? Scleral lenses and adaptation. So, adaptation means two different things in the eye care world. In Europe, they use the word adapting lenses to mean fitting lenses, where they choose the parameters that will fit your eye. And they use the word adaptation to mean fitting a patient with lenses. So I want to set that aside. That's not what we're talking about. But I am going to talk about adaptation in the sense of adjusting or getting used to lenses. In the old days of rigid corneal lenses, the small ones that we used, you definitely did have to get used to them. Why? It was a piece of plastic sitting under your lid and moving with every blink. And even with a perfectly normal tear film and a perfectly fitting lens, you probably needed to build up 2 to 4 hours the first day and so on. So there was an adaptation period. Scleral lenses don't move they shouldn't move, they shouldn't interact poorly with the lid. You should have an instant when they go on, okay? If the fitter picked one that at least has some shot of fitting appropriately. If it's way off, no, and if you've got a crazy funny shaped eye because of keratoconus or a big blab, or you've got a big notch in your lid because of your squamous cell cancer that got taken out, it's going to be different. But for your average ocular surface disease or dry eye patient, we should put it in. Some patients blink like this and say, ah. I mean, it's one category particularly, my graft versus host disease patients. They say, can I take these home? They want to walk out with a pair I just stuck in their eye. They don't even care if they can see in them. They want them. You should have the instant on. Now, not everybody's like them. Some people are blinky or sensitive. Sometimes some of our patients are sensitive just to touching the face. So they need 10 minutes, but that's how long it takes me. I've got to make sure there's no air bubble. I look at the haptic. I look at this. Then I want to measure their vision in that one lens. And then I say, how's it feeling? And if they say, take this thing out of my eye, I can't stand it, then, and I think the fit was okay, that's already telling me they're not a candidate, okay? And trying more lenses by more doctors or trying to get used to them, if you get ones that don't feel good and you're sent out of the office with them, no amount of adaptation is going to happen. And it was this problem of these ocular surfaces, these dry eye patients who had perfectly fitting lenses from our assessment at Boston site, where we did an awful lot of this, who were profoundly symptomatic. Some felt good for 10, 15 minutes, but by 30, 40, 50 minutes, get this thing out of my eye. And those were what turned out to be what I call the pain or hyperalgesic patients. More tidbits on scleral lenses. I don't ever believe it's an answer for soft lens intolerance. We hoped it might be. Gee, you have a soft lens that sits on your cornea, it acts like a sponge, it sucks up whatever tears you make. Maybe a scleral lens that's bathing your cornea in moisture will be more comfortable. Generally, that's not the case. So I don't offer or push sclerals on patients who are intolerant of soft lenses. Gloria, I don't know, I'm putting you on the spot. It's just not an answer. I also think when I'm sent ocular surface disease or dry eye patients, people who are complaining and their doctors don't know, go see Debbie Jacobs, she'll try out scleral lenses. I review the charts, and I usually will try the lenses, but I can predict who's going to reject them. They're rarely beneficial to those who are 20/20 naked, okay, or in glasses. Because to put up with the hassle of getting these things in and out of your eye every day, spending the money on the solutions, cleaning them, soaking them over that, you need vision as a driver. If you're not going to get the effect, then you need to see better. But if you're 20/20 naked or in glasses, you're not going to see better because the sclerals have a front, they have wetting defects, they fog. There are real issues with them. They're not perfect. So if someone has discomfort, but there are two 20/20 naked, it's less likely they're going to be happy. Occasionally I'm surprised they get that effect, and then we say, okay, and we do our best to get rid of the fogging and the wetting issues. But generally, if you're 20/20 and naked, it's not 20/20 naked or in glasses, they're not going to be a solution for you. The office trial sorts this out, so it makes me sad to hear there are people who might be candidates, but when they try to book an appointment, they hear it's not covered by insurance, and so they don't go. Because the initial consultation can be billed as a medical visit, whether it's an OD or MD, and you can bill for time. So there absolutely are pathways, and this is what we figured out at Boston Site, that there can be legitimate mechanisms to sort out if a patient is a candidate or not. That should be covered under your medical insurance. It's not a contact lens exam, it's not a contact lens fitting, it's not adaptation. It's a medical consult where we put a lens on your eye to see if it helps you feel better and see better. There are some people, though, who are told they have dry eye. We put the lens on, and they either can't stand it immediately or they can't stand it after half an hour. And it was trying to figure out what was going on that I came to understand what neuropathic pain is. Because one of the features of neuropathic pain is hyperalgesia. Things that are minimally painful are very painful, or things called allodynia, things like just moving air or smells, or light touch, things that should be tolerable feel like pain. And people with neuropathic pain generally are exquisitely sensitive to the presence of the lenses and won't tolerate it. And this was what got me interested in this topic now of ocular surface pain. And in working with Dr. Rosenthal and trying to sort out who did well and who didn't with scleral lenses, we wrote this paper, Corneal Pain Without Stain. Is it real? Postulating that they have neuropathic pain. And that phrase is mine. I really didn't brag about it, but I did make up the title, and it's totally caught on. Everywhere people talk about the pain without stain patients. So I am tooting my own horn here after 35 years, and it is real, but it means the problem is not on the surface with staining, it's the nerves are firing when they shouldn't be. So thank you very much, and it's a privilege to be here and have a chance to share my sometimes strong opinions with all of you. Thank you, Rebecca.